Hey everybody, Dr. Becker. For chapter 1, I wanted to jump in and record a video to help highlight the most important part, honestly, of the history and physical portion is the history taking. So chapter 1 is a great chapter. I love the way that this book, Rhodes and Peterson, outline this chapter. I think it's very well done. So really take your time to read it, take notes, highlight on it, and really absorb it. As you guys move out into clinical, as we've already talked about, I want you guys to be able to get comfortable in taking a history and beginning to know how to ask questions in a purposeful way that follows the format so that you can have this to where you're so comfortable doing it and it becomes routine that you just ask the same questions in the same flow, the same way the majority of the time. And that's how you build it as a skill. I cannot overemphasize the importance of taking a good history. I would argue that if an error does occur in the process of taking care of a patient, the far majority of the time it happens because we don't ask the right questions and we don't know how to listen. When you're dealing with any patient, you have to be able to give them your time, your energy, your attention, but you also have to know how to keep the interview moving along, and you have to know how to be able to tease out the information that you need. So I wanted to kind of walk through this with y'all and make sure you really have a firm understanding. All of the chapters have their own slides. I think they're very well done. I think it would make sense if you wanted to use these as notes, like print them off and take notes alongside them. I think makes sense too. So again, you're reading this. I know you've listened to your chapter, hopefully, or read through the chapter. The reason that we have the interview and the history, the H&P, and that's why we document it so thoroughly, it is the biggest piece of communication, and it's the way to reflect the communication that happened. It's not just to take up your time. It's not just to create work for you to do. It is a communication document, and anytime you do a note, but particularly an H&P or some kind of comprehensive note, there's going to be a lot of people that are reading that note. Now, I don't say that to like intimidate you, but if you think about it, okay, there's going to be, if you're the provider and you're making an H&P, let's assume it's a hospitalized patient, then that goes under the chart. The nurses read it, your fellow providers read it, consultation people read it. All of the ancillary therapies are going to read that H&P, PT, OT, speech, pharmacy, any consult that you do, they all are going to go back to the history and physical. And so part of your job in your history and physical is you are outlining your thought process, you are outlining what you did, but you're outlining the things that your thought process. So by that I mean the things you considered and then didn't think were appropriate. Right? You're also documenting your thoughts in the way of, I considered this, but it doesn't appear to be that because A, B, and C. So you're documenting positives and negatives, which is a little bit different maybe than some of the bedside nursing that maybe you've done through the years. So when you're talking about respiratory, if I were documenting my respiratory exam, I would say, like, as a nurse, the lungs are clear, upper and lower lobes, okay? And we kind of stop there typically. That's our assessment. When you're doing it as more of an interview and a history and physical, now you're going to be saying things like lungs are clear, upper and lower lobes bilaterally, and then you're going to say things like, you're going to be recording the lungs are clear in the upper and lower lobes, no wheezes, rales, or rhonchi, okay? So we're also saying what we heard, but we're also documenting specifically that we didn't hear X, Y, and Z. And the reason for that is part of your clinical decision making. So it's maybe a little different than what you're used to in bedside nursing. It's not just the pertinent positives that you find, you're also specifying, I looked for rales or rhonchi and I didn't hear them. Same thing with the abdomen. Instead of saying the abdomen is non-tender, right? We go into much more detail. There is no pain or tenderness noted with light or deep palpation. And the reason, again, that we give those specifics is to show our thought process. I was looking specifically to see, well, do they have right upper quadrant pain or tenderness? No, they do not. So it's helping document your thought process. The other thing is that you are providing a legal record and you are fulfilling documentation for payment. Part of the thing that I struggled with for sure when I start, and I know a lot of new graduates do, is I really struggled with feeling like I was fluffing up, if you will, or intentionally writing more to try to fulfill a level for billing. And it can be kind of intimidating if you're getting feedback like, if you would have documented X, Y, Z, we could have billed at a higher level or whatever. And I struggled with that in practice when I first started. I would tell you this. You do your good, thorough H&P and forget about billing and do it the best you can and have a totally comprehensive thing. And then whatever that looks like on the billing side, it is what it is. So don't fluff up your charts per se, but honestly, if you do a thorough history and physical, you're going to meet the requirements. It's when people start getting too busy and they start to cut it to where they're not showing their whole decision making and documenting it, then that you lose out on how much you could bill for a patient. And at the end of the day, I'm not here to make the hospital money per se, right? I come to work every day because I want to take great care of my patients. However, I can't come to work if I don't make the hospital money to pay my salary, right? You know, money matters, billing matters. At the end of the day, it's a business and they can't keep their doors open if they have providers that are not going to do what they need to do to show their work so that they can get paid for their work so that the hospital has money to pay them, etc. So don't worry about making sure you're charting enough to get paid, but make sure you are being thorough and you're following those recommendations. Okay, and then you're serving as an essential element in peer review process for evaluation of clinical practice. The idea of if you didn't chart it, you didn't do it does carry over into this, okay? It is very difficult to defend your thought process when you don't document it. I mean, that's hard, right? Think about that. If someone says, well, why didn't you order XYZ? And you're saying, well, I thought about it, but because this was normal and this was normal, I ruled that out. And they're like, well, prove it, right? Because you didn't document that. So the positives and the negatives and being thorough and complete is laying the foundation for your clinical decision making. Really remember this, people struggle with this. Anything that is provided by the patient or somebody else during your health history is subjective data. Okay, they can say whatever they want to say and it is subjective and it's open to interpretation. It is based on the patient's perception and recall, or the family, whoever the historian is in the situation. That is subjective data. It's not quantifiable. Typically, it's subjective, right? Objective is measurable and verifiable, right? So objective data is what you see as data, right? So my physical exam, my questions, my review of labs, of tests, of medication summaries, things that are solid and measurable fall into objective. It sometimes can be a struggle for students when they're starting out. They start putting objective into subjective and subjective into objective. And we want to really practice this, that you're paying attention to what is subjective and what is objective. Remember that during the time you're doing the history and physical, it is also not just about making sure I ask enough questions to be thorough. You have to be able to be in your brain thinking through this format and making sure you are asking the right things, guiding the interview, asking directed questions. But you also have to be establishing and building a relationship with your patient. Okay? If they don't trust you by the end of your interaction, or at least believe in you, or feel somewhat confident in you, you are not going to have the best outcomes. End of story. The trouble is that in today's healthcare world, no matter if you're in an ER, a walk-in clinic, if you're in the hospital rounding, whatever, there's always this time and this pressure and your pager's going off or people are texting you. You know that you have to pick the kids up from soccer practice tonight, so you need to be done no later than 5:15, but you still haven't rounded on 3 other people and you're running out of time, and all of this is going through your head, and there's a lot of distractions, and then you're trying to be thorough and you're trying to think critically and you're trying to decision make, and all of this is going on. And you have to be able to manage all of that and then also look and make eye contact and listen to the patient and build that relationship. Also, when you're doing the H&P, we're respecting their autonomy, their self-determination. We want them to feel empowered and a caregiver partner. And we want to be mindful of how this process of getting that data can influence the relationship. Okay. This comes out to be things like, don't stare down at your notebook the entire time. Don't bring a computer in and stare all at the computer and just start asking them questions like they're in line at the DMV, right? You have to be able to have a relationship while you're also data collecting. Okay, there's a skill. It takes practice, which is why you go to your clinicals. Of course, you guys, I want you to read on the culture, but I'm going to leave that to the reading and pass through that. Okay, you guys read on this. The idea of two-patient syndrome is real. Sometimes, unfortunately, we're dealing with vulnerable people and families. Some are angry, some are hostile. Sometimes they're in a really raw or emotional state of their life. And so sometimes the provider-patient relationship is not always warm and fuzzy. I'm going to pass through these because you guys are going to read this in your chapters, and hopefully you already have. What I want to point out kind of is this here, is that we want to have the patient involved in giving us their history and feeling empowered to do so. Okay. I feel like these things are always kind of a no-brainer, that I always feel like everybody would just normally do these things. But let's talk about them, because I think sometimes it just doesn't cross people's mind. There is a new role that you are stepping into. Whether you've been an RN for 5 years, 10 years, 15 years, 1 year, 2 year, whatever your journey is. But now you're a novice again and you're learning this new role. And with that, being a provider I don't even know how the words are. It's not that you're better than a nurse, right? It's not that you're more professional or less professional. It's not that. But inherently in a patient-provider relationship, when you're a decision-making provider, there is now a different level to that of professionalism, okay? So they, generally speaking, providers are not going to show up, right, wrinkled, disheveled, with body odor, 8 shades of purple and bright colors in their hair, and 18 facial piercings, and just kind of this not business professional persona. And so when you go out into clinical and into practice, you have to be professional in your appearance, your behavior. You have to make sure you have privacy. You have to make sure it's quiet and a non-distracting environment to the best of your ability. You have to ask the patient how they want to be addressed. You introduce yourself and identify your role. Many people you're going to find don't know what a CNS is or a nurse practitioner, and you have to explain what it is that you do. Then you do request permission to conduct the history. Well, I need to get a history. Is it okay if we chat now? Right? That's how I often will say that. And then try to obtain the historical data with the patient fully clothed. Very important pointer. Don't get them exposed or practically naked and cold, and then sit back for a 30-minute conversation of asking questions. Very important that you position yourself at the same level of the patient. If there's not a chair in that ER bay, if there's not a chair in the urgent care, whatever it is, go get one. Make it a priority. Sit down and visit with your patient. Very important. The reason also for that is that the patient perception of the quality of your exam and your interview and the attentiveness you're giving them, they have studied this. For those providers that come in and sit down, you extend the patient's perception of how long you spent in the room. So they would time people. A provider would go in and stand, or a provider would go in and sit. And any time that the provider went in and sat down, the patients overestimated how much they thought they spent with them. So they'd wait 20 minutes, then an interviewer would go in and say, how long do you think your provider was in here? Most of them spent about 10 to 12 minutes in a room. If they stood, oftentimes they say, oh, 5, 10 minutes maybe. But if they were sitting down, then it was 20 or 30 minutes or 40 minutes or an hour. It was way more than the time was. And that's our human brain of the patient seeing a relationship built. They felt more heard, all of those things. Their perception is that you spent more time with them. So sit down. It's important to them. Recognize your potential personal biases. We'll talk more about this at the end of the semester when we go into immersion. Prioritize information needs. This can become tricky when you're a student because we really want you to be comprehensive for the practice, but sometimes you're in a position where you are in a walk-in clinic or an urgent care and they're like, you got to get in and out in 5 minutes because we need X, Y, and Z. So you do your best. Sometimes it's not ideal. Obviously in a trauma, we're not going to ask them their diet history and their cultural history and all of those things, right? So it's not always ideal to be comprehensive, but know kind of what the priority is in the situation. And address the questions to the patient, not the translator, even if one is present, and then allow that translation to occur. But even as you're talking, it's really easy to turn to the translator and tell them the question you want with eye contact. Don't do that. Maintain eye contact with the patient. Ask if it's all right to take notes. Assure the patient that the information you're getting is confidential. There's a way to use open-ended questions, right? So you don't want to give them yes and no questions. Have you had cramps? Have you had stinging? Have you had a headache? Have you had nausea? Have you had whatever? Were there yes, no, right? Instead, you can say things like, tell me about your stomach. How has that been feeling? Right? That's an open-ended question. That opens it up to say, tell me whatever you want to tell me. Help the patient become the partner in the caregiving. Make sure you give them time to respond. What I always have told students was shut up and listen, right? Let the patient tell you how and what is going on. If you give the patient enough time and you do your interview well enough, 99% of the time, in my opinion, the patient will tell you what's wrong with them. You will finally extract that key nugget of information that is the aha moment of, oh, I think they have whatever, whatever, whatever. Remember I said that if we start to make mistakes, it's almost always in the interview and history. It's almost always because we go in with a preconceived notion of what their diagnosis is. We only ask directed or closed-ended questions just to, in our mind and our bias, to come through, and we don't sit down and shut up and let them tell their story. Again, not because we're bad people, it's because we're busy and your pager's going off and all the things, right? So just in the back of your mind, sit down, let them speak. Now, it is an art. We have to learn how to guide the interview and not have it be where they take 47 minutes when they go back. Well, it all started in 1954 when I fell and broke my leg, right? We have to do that as an art, and you learn how to do that with time. You also are observing the nonverbal behaviors. Even though you're listening, you're watching their body language, you're watching how they're moving, how they're speaking. You're also watching their relationships with others in the room. There's so much going on for input during that time, so you have to be observant. Validate your perceptions with the patient. I love that one. That is when I will say things like, so if I'm saying this correctly, you were feeling pretty good up until 3 days ago. Then that's when that first nausea really hit you, got really bad, and then you had about a day where it wasn't so bad, so you thought, maybe it's getting better. But then on day 3, it just hit you again, and now it's never gone away. Like, did I get that right? Like kind of a paraphrase back, so you're validating their perceptions. Okay. You can come back around to any contradictions, and then be aware of prematurely cutting them off. Okay, so those are some of the basic pointers here. One of the things by the end of this semester that we want you guys to be comfortable with, at least attempting and doing, knowing you're not going to be experts, but being familiar enough that you think you could do a comprehensive history and physical, right? So that's the whole caboodle. And then we have focus notes. And those are ones where they're episodic things of care. If they come into your walk-in clinic and if they come in for a sore toe, okay, Now it's a problem-focused assessment, and you're not necessarily typically in practice trying to do a cultural assessment, right? You're focused on the problem, get in, get out, and move on, because it's a timeliness thing, okay? And so that can be a little tricky. Even in practice, if you have the time, if you go into a walk-in clinic and you're a student and they're like, I'm here for a sore toe, explain to them, I am a student at Augie, the nurse practitioner student, and I'm here, for clinical rotations. Do you mind if I take a couple minutes and ask you some history questions and then do a more thorough exam? I know you're here for your toe, but if I could also practice listening to your lungs and your heart and your abdomen, that would be awesome. And if they tell you, no, I'm in a hurry, okay, great, let me go get the provider. But often, more times than not, far and away, they're going to be like, oh, sure, go ahead, right? So even though you may be in a situation in clinical where you are a more focused exam, take every opportunity that you can to try to start practicing the comprehensive. But obviously, if there are 25 patients in the lobby and they're like, we got to get these people in and out, Sarah, you can't go in there and take 30 minutes. Okay. You got to be aware of the circumstances, of course. Okay. So comprehensive is typically when you're new to the patient or the patient is new to you, whether that's in an ER and they're going to be admitted and you're doing a complete H&P, in a primary care situation, or an outpatient new consult situation. Those tend to be a lot more comprehensive. The focused tends to be walk-in clinic, ER type of situations, or when you're doing daily rounding, or you've already gotten the information and now this is just the episodic today focused exam on what you're dealing with, right? So the more focused ones typically tend to follow what we call the SOAP note format. So by the end of this semester, we would love it if you guys could do and feel comfortable knowing that you could try, you're not going to be perfect, but you could dive in and do a comprehensive H&P and a SOAP note. The other types of notes that do exist out there, I'm just going to throw that in here that you may hear in clinical, right? A procedure note is something typically a little different, and that's more for billing and documentation purposes. But again, if you're in a walk-in clinic or an ER and you do a laceration repair with sutures, then there's a procedure note specific to that where, time, performance, what you did, how the patient tolerated it, those things. So there's a procedure note. People, if they do a surgery, then also do a surgery note. But typically in these situations between an H&P, a comprehensive, or a SOAP note, you're probably going to be just fine if we know how to do those two. These components of the comprehensive health history are all in your book. They do a great job of walking you through that. I suggest printing off under resources on chapter 1. I did a couple different PDFs. They're only 2 or 3 pages each, but if you want to print those off so that you can have those at clinical and not bring around a big book or have to go look into the ebook, I think those would be a great resource for you to have. Where it tells you, don't forget, you need chief complaint, HPI, blah, 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 and something, a template for you to go off of. Part of the focused health history is more of, who they are. This is Mr. Robert Smith, born on 1/1 of 1950. Chief complaint was sore toe, history, present illness, what pertinent data you need for the past medical, family, and social history, and then a problem-oriented review of systems, right? If a female that's 25 came in and had a sore toe, yes, you're going to ask pregnancy, of course, because you need to know that, but you're not going to go into when did you have your first menses? When was your last cycle? Or describe your cycles to me, those kind of things, right? Because that's not, we're not doing comprehensive things like that aren't applicable to their chief complaint. And these are really well done in your book. The chief complaint is their words. It's typically 1 or 2 words. I'd say no more than 3. Go through there, and on those resources, you'll print that off, and it's the PQRST, and then the mnemonic device client outcomes. Also, when I was in school, I learned old CART, onset, location, duration, characteristics, aggravating or relieving factors, remedies, and treatments. But now this book uses client outcomes. and then the past medical information about the patient's health and illness. In those resources, it talks about everything you should add to the family history, surgical history, social history, review of systems, etc. Okay, this is the PQRST mnemonic client outcomes, so that you have these as great resources. I'm going to, on the printout PDFs of this is how to do these. So hold on one second. Let me flip my screen here. So let me flip over to the ebook here. And these are in your resources that I printed off, okay? This is a great chapter to read on. Please make sure you do all that. See, in the book, it'll tell you all of the information in there of what you need to ask for each ones. What I want to go down to and show you guys is, these are great. See, it just tells you all the things you should add. So it gives you all the hints of everything you should ask in each one. So I gave you these as PDFs so that you can print these off for your resources if you're out in clinical. I wanted to show you guys when you go into comprehensive review of systems, okay, this is so important. If I were you, I would print out all of this down to have with you that you are using to guide you. You can tweak it, type up your own, whatever. But let's say you see a patient with an eye complaint that comes into clinic, right? So you're in the ER and they say, I have pain in my right eye, whatever. This is going to tell you everything you should talk about in some way, shape, or form. You need to ask them about injury, double vision, acuity, sudden loss of vision, tearing, blind spots, pain, blurring, seeing at night. Okay, it tells you this right here. So if you're in an ER or a walk-in clinic or whatever, and this is what their main complaint is, 100% you need to do that. Ask these questions. So when you're documenting your review of system, you would say, you'd put ROS, eyes, dash, patient denies any injury, comma, denies double vision, comma, denies any change into vision near or far, comma, denies sudden loss of vision, period. Patient has had unilateral tearing of the right eye for the last 48 hours, comma, denies blind spots, comma, has burning and irritation and some discomfort at times that comes and goes, comma, their ability to see at night has not been affected, period. The patient denies photophobia or halos or any headache, comma, denies any eye discharge, comma, denies seeing spots or floaters, period. Okay? So even if of all of these, there was only one thing that they did complain of, remember our thought process and our decision making is to be complete. We asked about all of it, so we're going to say they said yes or they said no to these. Okay? Now, because the main complaint was maybe eyes, right? In a focused exam or a SOAP note, we're definitely going to do a very thorough eye exam. But in a more focused one, some of these others would be slimmed down. Okay, so I love this. This is great. This is exactly what you need to know. So if you say, I don't know how to write, what was I supposed to ask about their neuro? Well, okay. Do you have headaches or lightheadedness? Do you have any history of convulsions or seizures? Have you had any trouble with your coordination? Have you had any sensory changes? Have you had any changes in your mentation or brain fog? Have you ever had any fainting or syncope? Have you ever lost consciousness before? Have you noticed any difficulties with your memory or your speech? Have you had any trouble with sensation or movement of your arms and your legs? Okay, have you ever had any tremors? Okay, they said no to everything. I would say neuro dash patient denies headaches or lightheadedness, comma, convulsions, paralysis, or incoordination or sensory changes, period. Patient denies any changes in mentation or fainting or syncope or loss of consciousness, period. Patient denies difficulty with memory or speech, comma, sensory or motor disturbances, period. Okay. What you might see in practice is when people cheat and they say neuro-WNL, within normal limits. If you want to remember a pearl to get through the rest of this program, never, ever, ever in practice or as a student put within normal limits, okay? For a variety of reasons. One, we need to know as your instructors that you know what was normal limits and what wasn't, so never do it in school. But also even in practice, it's not good practice. It really doesn't meet what we're looking for to show clinical decision making. Okay. So I just wanted to show you that here, guys, of kind of what this looks like. I would print that out and see what that would be or what that would look like for you as a cheat sheet that you can refer to in clinicals. Okay. I was going to point out that these then are the comprehensive review of systems, right? So typically if you're going to do a focused one, it helps you out here. For example, a known adult who reports substernal or epigastric pain would be asked questions related to cardiovascular, respiratory, musculoskeletal, GI probably, and you would only focus on those and you would kind of narrow it down in here, okay? So I tried not to drone on too long. I hope that that was kind of helpful as you've read through this. But when you get to practice out there in clinicals, we are not asking you to come back and turn in any SOAP notes or H&Ps about the patients you're seeing in clinical, okay? We are going to, as you'll probably already see, we're going to go through case studies where we practice writing a SOAP note and a directed guided interview that way. So instead of worrying about making sure you see a patient and whatever in practice, I want you to go to clinical, get your hands on the patients, do as many physical exam components as you can, practice interviewing, practice, and be focused on that. I'm not worried about you guys writing SOAP notes to turn back into me about the actual patients you're seeing in practice. You do, however, have to log in Typhon every interaction you have. So that part you have to keep track of. 37-year-old female with sore left toe, and those data that Typhon needs, that's what you have to get, and then go on. You don't have to worry about getting those things for me in Typhon to write any SOAP notes. Good Lord, I'm getting emails. Okay. As always, reach out if there's any questions or worries or thoughts or concerns about that. But I would really, really focus on this chapter and refer back to it because this is a great explanation of how you document an HPI, or excuse me, an H&P. Thanks, guys.